Hi, you guys are hi. Batty too. If you hear no lab, you don't have to respond. So someone will text them if they don't know. They're just giving me lip service. Okay, let's pick up where we left off. So this is respiratory. We're going to start digestive. But this animation, I'm sure, will be part of the thing that's there. You might recall we're in this area. We did the thing, we did the thing, we did the thing. Oh, here we are. So all of these things, this is where we left it at hypoxia. Anything that causes inadequate oxygen delivery to tissues results in, and it's characterized by cyanosis. Cyanosis, someone is cyanotics, they get, you can see it in their nails, their fingernails, their toenails, their lips. They get that bluish kind of a color that really is indicative of inadequate oxygenation. So when you begin to see, and really that's something, when we see that clinically, in an emergency room, you react very, very quickly. Okay, anemic hypoxia. Okay, that we see that in people, their color changes. You don't see so much cyanosis with that. Since I had such severe anemia, if anything, you were much pale, was really the color. When someone is truly anemic because of a lack of red blood cells, the paleness is the predominant color. I remember going into the medical unit. I was on my way to get a transfusion, and they saw me barely walk in. They go, "Oh my goodness!" And all of a sudden, they're shoving a wheelchair under me, and "Oh, you look terrible. You look really dehydrated." They started pushing fluids, and I was that kind of sick. We're still working and seeing patients. Okay. So again, you can have hypoxia, impaired or blocked circulation. That's probably, we see ischemia more regionally, like a diabetic with a blockage going into an extremity. The heart would be ischemia, to the brain would be ischemia. Histotoxic is a fancy name for poisons. Most of these quote unquote metabolic poisons, cyanide being a perfect example, they alter they interfere with the actions of the Krebs cycle, citric acid cycle. So they have to interfere with some of those proteins that make up the electron transport chain. Is my recollection. I'm not a toxicologist. Okay, hypoxemic, very, very common, either low levels of oxygen in the air, but more importantly, what we see mostly, pulmonary disease. And I'm not going to laundry list to you. This is more background information. And this is so important. Carbon monoxide poisoning. Understand that it's molecular. Oxygen and carbon, the difference molecularly, when you look at O2, carbon monoxide, very similar molecules. Interestingly, the shape of the carbon monoxide molecule is a better fit on the heme unit than oxygen. That's the best way to explain it. It has, because of that affinity, effectively, once it contacts a heme unit, it's not leaving. We use hyperbaric oxygen and people erroneously teach that, well, we're forcing oxygen in. You're not forcing in to the point of 200 times more. It just doesn't work that efficient. What you're trying to do when you give somebody hyperbaric oxygen, let's say a classic example would be a firefighter who has exposed to carbon monoxide because of problems with their ventilation equipment. There's a very famous movie, I think with the late, I just cited his name before. Call Backdraft. The name will come to me. So, nevertheless, They showed the firefighters, they're like plastic coffins that they sit in that are clear, at least they can see out, so they're not as claustrophobic, having to be in there. Patrick Swayze, the actor. And it was a really good movie that depicted some of the problems of cold backdraft with the fire. But understand that that's the tragedy of carbon monoxide poisoning. If you don't get to them as soon as possible, if they're still alive, immediately start oxygen. Use hyperbaric oxygen. The whole idea is to optimally oxygenate every red blood cell other than the ones that have carbon monoxide, because red blood cells have a lifespan. And so you're going every day, you're going to gobble up red blood cells that are near the end of their lifespan. So every day that you survive with someone with carbon monoxide poisoning, there increases their odds of living, because you're making new red blood cells that you're maximally oxygenating. The whole idea. The damage is done. And that's why it's so tragic. What happens is, that's the kind of one where we'll see it when they're, people do this inadvertently, and they do it by design if they're trying to commit suicide. Yes.
Be able to have a blood transfusion to fix that then?
You probably could. But then you have to find compatible blood, and they have to be able to tolerate it. The ability to tolerate. I mean, your oxygen carrying capabilities. A lot of times you can do procedures. Question is, will the patient survive the procedure? So their overall health has to be taken into consideration. So would you do it? Yes, sir.
What would happen with the carbon monoxide? Once it's digested, I guess it can take a second.
Pardon me?
What happens to the red blood cells?
Oh, they have the carbon monoxide. I mean, they're gobbled up in the spleen or in the liver. I mean, they're no problem. Particularly, once the carbon monoxide hits them, they're useless.
Yeah, I wasn't sure if the carbon monoxide.
Oh no, the carbon monoxide. I mean, it would not cause further problems. Would be the way to describe it. Maybe to some extent that plays a role with the free carbon monoxide. What happens is that they turn, for lack of a better way to describe it, and usually by that time the person's gone, they turn pink. Someone who's Caucasian will have a pinkish color. So it alters the hemoglobin in such a way that it produces a different color. It was first noted, so I hate to reveal the context, before they used Zyklon B to exterminate the Jews during the Holocaust, they used carbon monoxide. They just found Zyklon B was more efficient. So they actually were using buses reversing the exhaust that were airtight and load them up and run them, and then kill the prisoners, and rinse and repeat. Literally rinse out the inside and repeat. That was the original way until whatever that pharmaceutical, it'll come to me again, developed Zyklon B to use in showers, such as they were showers. So that's the context, I think. It's there. So people know that, and we see people when they're in a garage, things like that. Didn't I tell you the story about the couple? My now 39-year-old daughter and this couple's granddaughter, when they were in preschool together, hung out. They had a wonderful gift shop that was one of those little treasures of Squirrel Hill, right off Forbes Avenue up in Squirrel Hill, and if you're familiar with it, by the Jewish Y that's up there, all in the shopping. Nice spot. And they were just off that on another street. We great gifts. And the grandfather and grandmother of the little girl, we were friendly with obviously the man and the wife were part of it. They had a really nice upscale condo in Oakland, carbon monoxide poisoning. Certainly not by intent. It was a bad oven. It gave off carbon monoxide, a gas oven, boom. Bad ventilation, and I think one died and one was permanently damaged. One, oh my God. The funeral My wife at the time went to that, we're talking around the corner, people paying their respects. We do it a little differently in Judaism. It's after, we call it Shiva calls. So they bury very quickly. A lot of times it'll be the immediate family, and then there'll be another, depending on how religious you are. Let's say the average, as little as 3, as much as 7 days of Shiva, where you're basically, the idea is you're trying to, people who are gone. You're trying to support the family who's left. Just a little religion wouldn't hurt. So it's a very, very interesting. It's fascinating, and interestingly, we inhale it all the time. It's in car exhaust. I mean, if you want to make, look, the whole argument, and I know nothing about environmental science. I know less than nothing. But if you want to make an argument about gases and exhaust and secondary smoke and what we're breathing, that could be part of it. Because carbon dioxide came out of cigarettes also. On the other side, I keep wondering what's going to happen to all those giant car batteries. What are we going to do with them eventually? So you find in life that you can't necessarily, when you try to make something to take the place of something, it was one of the premises of the original book Dune, when the idea is it was all about what they call planetology, planetary ecology. You can't impact one thing on the planet without impacting something else. You have to do it very, very slowly and very gradually, which is not something we do culturally here. Let me hear you.
Whether you're racing in a triathlon or doing something less strenuous, you need to breathe in oxygen to help you get energy. And breathe out carbon dioxide, a waste product. When you inhale, your diaphragm and rib muscles contract, increasing the volume of your lungs. When you exhale, these muscles relax, decreasing the volume of the lungs. When the lungs expand, air pressure in the lungs drops, causing air to flow into the lungs. When lung volume decreases, air pressure increases, causing air to flow out of the lungs. Air enters the nose or mouth, moves down the trachea, and goes into the 2 bronchi. Air moves down smaller and smaller bronchioles until it reaches a tiny sac, an alveolus. Each alveolus is surrounded by capillaries. Oxygen diffuses from the alveolus to the blood, and carbon dioxide diffuses from the blood to the alveolus. As blood flows through the capillary, it becomes rich in oxygen. In the blood, oxygen diffuses into a red blood cell and binds to hemoglobin, a protein made up of 4 subunits. One oxygen molecule can bind to each subunit. Oxygen-rich blood flows from the lungs to the heart.
It's a great concept of the interior.
Which pumps this blood to capillaries all over the body. Here, we see oxygen diffusing from a capillary's red blood cells into a muscle cell. Oxygen is used by the cell's mitochondria to produce ATP during cellular respiration. Carbon dioxide is released. How does carbon dioxide leave the body? Carbon dioxide diffuses from cells into capillaries. Some carbon dioxide stays in the plasma, the liquid part of the blood. Most carbon dioxide, however, enters red blood cells. Some carbon dioxide binds to hemoglobin. The rest is converted to bicarbonate, which diffuses into the plasma. This oxygen-poor blood flows back to the heart, which pumps it to the lungs. There, carbon dioxide diffuses from the plasma into the alveolus. Bicarbonate enters red blood cells and is converted back to carbon dioxide. Carbon dioxide is also released from hemoglobin. Carbon dioxide diffuses out of the red blood cells into the plasma and into the alveolus. When you exhale, air flows out of your lungs. And that's how you release carbon dioxide, get oxygen, and keep on running.
Interesting. I mean, I love their animations when they do this. I mean, it's pretty straightforward. It's all about higher brain centers and then various kinds of receptors. There's chemoreceptors, and as much as anything else, and effectively they're pH-oriented receptors as well. So you have the medullary and the pons. There's a couple of groups. There's two in the medulla, one in the pons. They sort of complement each other. I mean, I just think that's sufficient. Effectively, they generate the rhythm that you and I, whatever our normal rate is. And we obviously adjust it for degree of activity or need. And I mean, the analogy of what happens, okay, a little bit different when they talk about forced expiration may involve a separate group rather than passive respiration. So we think passive rather than forced. So I mean, you're looking at like, you know, if you're working out, all of a sudden, I mean, I might be on the treadmill, all of a sudden I can see my heart rate's going. I want to bring it back down to the range I want. I'll just puff out more, comparatively speaking. You know, I like to keep it between 110 and 120. That's just age-wise, that's probably appropriate for me. But in general, we don't control. It's again, the analogy is like a metronome that maybe somebody you may have had if you had instrument practice, or in the old days when people took piano lessons. I don't know. Okay, my athletic ability is exceeded only is exceeded only by my musical ability. Both of those are zero. So this is the set, normal breathing, eupnea, okay? And again, that rhythm, it's all about the diaphragm, flattens, expands the cavity, intercostal nerves, the external, effortlessly. Basically, the only active portion of breathing is this, normally, okay? And understand that when expiratory neurons inhibit inspiratory neurons. So there's almost like, you know, effectively you're creating a cross. When you're inhaling, it's basically advising the inhibitory ones, the inspiratory ones. So if you're inhaling, it blocks the expiratory. If you're breathing out, it blocks the inspiratory ones that are there. And they look at these. There's stretch receptors that are involved. There's chemoreceptors that are involved. And effectively, it works. All I can tell you about. So you don't have to go crazy with any of this stuff. It's when we see problems, okay, in one of these. That's why when we're dealing with brainstem injuries, it is so difficult. These folks, this is when, you know, when you're having, this is someone who's going to be on a respirator a long time, potentially, and inevitably that's fraught with danger. Sooner or later, pneumonia is going to rear its ugly head. It's not long-term survival when someone has to be either on a respirator or only can be weaned off it periodically. Never good. Never good. They're just going into an assertive amount of detail. I don't think it's necessary. So, origin of breathing understood. Pacemaker neurons, could think about that. Reciprocal inhibition seems to be, as I was talking about a little before, interconnected pacemaker neurons generating a rhythm. Again, when you say this is a widely accepted hypothesis, again, what is this code for in real life? We don't know. If we don't know, how can I ask you about it? Other than say, do we have an idea, or is we still misunderstood or not understood completely, like in a true false sense? That's the type of question. Okay, and again, depth is determined by how actively it is being stimulated. Do I have to breathe more aggressively in or out? So all of those changing by really it's body demand. Sleeping, you have less. Activity, you have more. And so these are the factors that influence it. Chemicals, higher brain centers, irritants, even inflation. This is where it involves stretch receptors. Most important factors, not in order. The least important of the three of these is PO2. We saw the not, that S curve, that is the hemoglobin dissociation curve. If you have to rely on partial pressure of oxygen to cause you to breathe, you are in big trouble. It's all about CO2 and pH, and they are interlinked. And you see up there, I mean, because I'm doing the respiratory unit on an easier way with the A&P classes, but this is again, just like we're going to do it again in kidneys, but the old carbonic acid bucket. Water and carbon dioxide in the bloodstream, carbonic anhydrase, reversible. Okay? So we can move back and forth, we can adjust for increases and transient increases in acidity, alkalinity, alkaline tides. They make carbonic acid, weak acid. We've talked about that. It tends to hold on. Weak acids just don't dissociate rapidly. So effectively, again, it will hold on to the proton or it will give up the proton. It's versatile enough to do that. The difference is why this is such an impactful thing on breathing. Breathing is major controls of breathing are here. Cerebrospinal fluid. Okay. To get there in the cerebrospinal fluid, the only thing you can get there is carbon dioxide. Protons, charged particles, don't cross that barrier. The other thing that's there, or not there, in the cerebrospinal fluid, there's no carbonic anhydrase. And so what's going to happen in the absence of carbonic anhydrase, all of that CO2 is going to form carbonic acid, and it's going to increase the amount of acidity, or in this case, lower the pH, because the terms the same. And that is going to have a tremendously strong. So you can look at it as high PCO2 or low pH, increased hydrogen ion concentration. What's the eventual impact? They're going to induce your brain to breathe. Someone does a free dive. What do? They blow off to stay under longer. They take 3 breaths to cleanse, basically to blow off as much carbon dioxide as possible. Okay, take it in and blow out as much as you can. Do it again, then take in your final breath in to hold, and down you go. Because you're reducing the CO2 that's necessary for that. It's that kind of a stimulus that's so important. They're sensed by central chemoreceptors, that's in the brainstem, and where the peripheral ones are in the aortic arch and the carotid arteries. Again, the same place when we talked about, we used to call it, I mean, these are chemoreceptors. Another name, we call it the aortic body and the carotid body. Remember, the pressure receptors that were associated more with blood pressure were called the aortic sinus and the carotid sinus. Effectively, that had more of an effect on heart rate and force of contraction. That's where that was. Well, it gets done so well. Dr. Dress. God bless. So, most potent and most closely controlled, if blood PCO2 levels rise, excessive hypercapnia, CO2 accumulates, brain joins water with water to become carbonic acid, releases the drops the pH, increased hydrogen ion stimulates central chemoreceptors of the brainstem, and basically the respiratory centers got to blow that stuff off. The only way you have to lower the blood PCO2, and when you're doing that, it'll bring the pH back up where it's supposed to. The only thing you can do is exhale it. So that's why it's so critical if someone's doing a dive like that. That's the only way they could, if they didn't take the precaution of purging as much CO2, it would shorten the duration that they could be underwater at that point. Okay, and so if blood PCO2 levels decrease, respiration becomes slow and shallow, apnea, breathing sensation that may occur with normally low, and here's the hyperventilation, the whole breath, blah, 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 blah. Yeah, I mean, doing, and again, I don't know what the modern swimming science is with regard to, I really don't. Fortunately, I'm just giving you some ideas that we look at these things historically that are there. Hyperventilation, increasing depth and rate of breathing that exceeds, and what's the typical thing? Anxiety. People start to hyperventilate when they get excited. So you're blowing off too much CO2. And it's interesting, look what happens. Cerebral vasoconstrictions, ischemia, dizziness, fainting, and all of these things people start to go through. And yeah, it's the old story, breathing into a paper bag. So effectively you're rebreathing air that's richer in CO2. And you just have to find a way to get that person to do it, to understand the importance about that. I don't get that excited about anything, other than if the Steelers are having a really horrible game. Okay. I was even willing to give my wife a win yesterday. I'm a Yankee fan, but I like the Pirates, and she's a diehard Pirate fan, so I was happy to let her have one. What? No, I didn't want her. I didn't want her. I was afraid she might hurt something. The cat could have been in the way. There could have been a couch cushion going in the cat's direction. So she's not a great admirer of our relief pitchers, if that's what you want to call them. The only relief they offer to is to the other team. They're banned. Baseball game, bats, gloves, balls. So, PO2. Yeah, they said declining PO2 normally has only a slight effect because we have a lot of reserve. Remember, we have a lot of oxygen in our bloodstream anyway because we still have 3 of the 4 hemoglobins typically covered. So it has to be a substantial drop. And once you're getting down there, now you're in danger of it dropping precipitously because it's that whole thing about changing the shape and unloading. Okay, arterial pH can modify respiratory rate. Okay, again, chemoreceptors decrease it, may reflect CO2 retention. Lactic acid ketone bodies. This is something that we'll see. This is a ketoacidosis in a diabetic. Conceivably could put, and we'll look at this a little bit. Typically, we see things like respiratory acidosis and respiratory alkalosis. Metabolic. This is what they're talking about here. Is metabolic acidosis, probably. The accumulation of lactic acid and ketone bodies would be a diabetic acid out of control. When we talk about respiratory acidosis, it generally means people, it's chronic lung problems. They can't get rid of the CO2. In both cases, CO2 is being retained. They are much more common, metabolic and respiratory acidosis, than their opposite numbers, alkalosis. Respiratory is typically hyperventilating. Most of the time when you get alkalosis metabolically, is people are, because they take too many things like Tums. They take too many antacids and they just slug them down because they have so much trouble with acidity. I mean, they keep drinking or they keep eating the wrong thing. I mean, I had that with my chronic ulcers. I mean, I get one of those big, generic things, Tums. Chew 6 at a time, so I got some relief so I could work. Not smart. And so this is CO2 levels most important. PO2 affected only indirectly by way of the chemoreceptor sensitivity. Okay, to changes in PCO2. Again, if it falls below 60, big problem. Okay. And then there's other brain centers that certainly play a role in it. The hypothalamus. Again, this is where in the limbic system, remember that's emotions. Okay. So these are the kinds of things, okay. Obviously body temperature, not, it's also hypothalamic. But breath holding that occurs in anger or gasping with pain. Yeah, that you could make a case for that. Okay. Voluntary breath holding leads until the brainstem reinstates breathing when blood CO2 becomes critical. To me, I guess that's like the little kid holding their breath. The reason they can't, I'll hold my breath and die, and you'll be sorry. Not yourself. Just go ahead. Go ahead. Have a tantrum. I don't care. Sooner or later, you'll stop it. Tension, revenge, psychology 101, control. Why do kids do those things? We have a cat who's doing this now. Cat DDD. Go ahead.
Isn't that why people die?
What?
Isn't that why people die? Brain cells get dead.
Yeah, absolutely. You can't control it. You can't. I mean, you can't physiologically hold your breath longer than you physiologically can. And this is what happens. Sooner or later, you're forced to inhale water, gets in your lungs. Now, school's out. Unless you get some people quickly enough, and get them out, somehow get them to start breathing. So whether I guess you do CPR in the old days, you had those things. They would use their arms try to get them. I guess CPR is now the treatment of choice for that. Don't know. I haven't upped in CPR in more than 20 years. It's okay. And these are the irritants responding to dust. We all have this happen. Mucus, fumes, okay? Reflexive constriction of air passageways, triggers a cough in the trachea or bronchi, a sneeze in the nasal activity. We all get this. We all notice it. Herring-Brewer, okay? Stretch receptors in the pleura and airways by lung inflation. So, and basically, the stretch receptors tell us when to end inhaling and allow exhaling. Okay, and really, it's. I think it's basic. I acknowledge the statement here. It's more protective between being hyperstretched, between being excessively. It's not like every time you're not going to go. So that's probably a reflex that's there only if your normal controls for some reason are not adequate at that point. I would think more than anything else. And exercises we can adjust dramatically 10 to 20 times. That's pretty impressive. Okay, in response to metabolic needs. So if we're doing exercise properly and getting a sufficient amount of ventilation, I mean, whether you're doing it aerobically or non-aerobically, you shouldn't have dramatic changes. My context is just, listen, I'm trying to do this 4 nights a week, 4 days a week. What? Hey, who's going to take care of me but me? You don't want to stick my wife with me being sick. I'm the world's worst patient. You don't want me as a patient. She smacks me every time I have to go in for a hospital procedure. She has such a wonderful, loving way of expressing it. She goes, every time you're a patient, you're a fucking ass.
Should be,
Wait a minute, where's the context here? Why?
Because I'm just a pain in the ass to the people in the hospital. Whenever I go into outpatient, inpatient, lab, doesn't matter. She gives me one of these every time. You just said,
Do you deserve it?
what? Oh yeah, no question about it. I'm a pain in the ass. Go ahead.
Do you think that's because you're a doctor? Or
No, I'm sure doctors make the worst patients.
So if you weren't a doctor, you think you wouldn't?
No, I just wouldn't be as bad. I wouldn't be as bad. I'd still be bad. I held them to a high standard. They're laughing at me, Bill. That was Dr. Dress. He has my A and P students in micro now, mostly. They got the easy micro guy. Okay, so, and these are, when you exercise, it's interesting. I mean, I get out of the car at the gym. If you can test, if you have like a Fitbit, you can look at your heart rate, or like an Apple Watch. Watch it. You'll start to do that. Anticipation of exercise. Your muscles start to get used. Respiratory centers, excitatory impulses, proprioceptors. Everybody, he's going in for a workout. Get ready. Oh, again, I'm so tired of it. You can hear them talking to each other. And again, gradual decline to baseline is due to decline in CO2 well after the exercise ends. Exercise leads to, anaerobic respiration, lactic acid, etc. It's not from bad function, okay? This has to do more with whether it's cardiac output, but really the skeletal muscles as they contract. You're going to get a certain amount of lactic acid you're going to have to deal with to a certain extent, even aerobically speaking. And then the whole altitude thing. It's the quick travel. That's what happened to me. Is that acute mountain sickness. I mean, I'm telling you, that was awful. For me, it was all headaches. It was just crazy. And they were all wearing stupid masks. Because Colorado, it was like, the only time we could take off the mask when we were in a room. At least you could wear a bandana or something over your face. It didn't have to be like one of those N95 masks. I'm in the grocery store trying to shop because you're going to do all your own food, one of those, like a timeshare. Oh my God. And so it does take a certain amount of time, respiratorily, hematopoietic, and it took me about 24 to 36 hours for that to happen. More responsive to PCO2 and PO2 declines, etc. Increase in minute ventilation, stabilize in a few days, etc. Those types of things. I thought that was very interesting. So less oxygen available, and so what happens, the low oxygen stimulates your kidneys. That's the erythropoietin. So effectively, you want to say it thickens your blood, fine. It just makes more. It's a slow adjustment. And that's why they learned in sport. It's not something that happens. Going a few days early is not going to do it. Going a month early, minimum of 2 weeks to start to get those adjustments. That's why like World Cup venues, I don't know if they're having any in elevation. Maybe they are here in the U.S. 26, if they're having them in Denver. They are because they're going to be at they call it something different. The Azteca in Mexico City, pretty darn high. So those teams are going to be going there. Are going to come up. They always do. Exactly. All right, let's stop it here. There's very little to finish up with lung disease. Doesn't take long. All right. So anybody late to the party, understand? I'll record something and send it to you.